Is this how we change things? A little box? Okay. All right. Well, thanks, everyone. I appreciate the opportunity to come talk today. I actually watched most of this morning. I had the intent of putting it on Zoom and then getting some work done, but I didn't because it was exceptionally engaging. So thank all the presenters, Dr. Box, Becky, really beautiful stories. To Lori, thank you for getting my amygdala ready for this talk. And even sitting there listening to Dr. Bird, I think Jeopardy probably missed an opportunity for one of their co-hosts. But I appreciate this. I'll talk a little bit about what we're doing in our agency to really transform the way we care for aging Hoosiers in the state of Indiana, particularly building upon work we started before COVID-19 and really how COVID-19 has escalated that work. So to start, I would ask a question of all of you. I'd have you take just a few seconds to sit and think, where do you want to age? Where would you like to spend the last years, decades of your life? What location? What would really, in your mind, be meaningful? Where do you see yourself? So that's a good place. I'll give folks just a few seconds to truly think about that. If you're like most people when this survey question is asked, some surveys it's 75% or above, others it's 90%. You say home, my home, right? Which makes a lot of sense, right? As you get older, what do you want to be surrounded by? You want to be surrounded by memories. You want to be surrounded by the place where your kids grew up, where your pictures are, where the things you put in their place were. We know that. Now, 75–90% of people want to be there. When we look at Indiana, particularly those on Medicaid and those who meet level of care, about 50% of them are able to age in their home and community. And so, in part, our job and what we're reforming for is how do we move that number up? How do we make it easier for folks to be able to age at home? Oh, I got some yellow on there, but that's okay. And so, for us, this is really work that we're trying and collaborating with others to undertake. And as part of this work, really we're looking at 3 drivers. So if we want to reform the system and we want more people to age at home, what are the 3 drivers that we want to accomplish and that we want to look at for all the decisions that we make and all of the things we're doing? Number 1 is choice. We want as part of this that more individuals get to choose where they age and that they have a real choice, a real option, not one that is made in a crisis where they don't really feel like they have options. 2 is we need a system that's sustainable. We need a system that we can continue to afford even as the population continues to age. We know over the next 20 years we're going to see a substantial increase in the number of Hoosiers who are over 65, 75, and 80, and therefore likely the number of folks who will need long-term services and supports. Right now, when we look at the population in Medicaid receiving long-term service and supports. And when I say that, it's the whole continuum. It's home health, it's care in an institutional setting. When we look at that, it's about 4% of our Medicaid enrollment. So a fairly small percentage of folks who are on Medicaid get LTSS services. But it's about 30% of our overall spend. And that's similar nationally. It's about 40% in general of most Medicaid spend. So it's a small population, but it's a costly population, in part because of the complexity of the medical problems that they have. But if that population is going to continue to grow, how is a state or any state going to be able to continue to provide high quality services unless we can start to think about ways to control that cost? And lastly, and most importantly, is how do we assure quality? How do we make sure that any system we have, current and future, results in high quality care being delivered to individuals, regardless of whether that's care is in their house, whether the care is in a hospital or in a nursing home. So we'll talk a little bit about all of these. So this is the Indiana population, and if you look at this, over the next 20 years, you're going to see substantial increases in the number of individuals over the age of 65, and really the highest growth in those individuals over 75 and 85. The exact population that we know is at greatest risk right now of requiring long-term service and support needs. And if you look at the projected costs with this, again, you're going to see substantial increases in costs if we don't do some things to create a more sustainable system. So when we look at this as a whole around the country, on the left-hand graph, this is sometimes the terminology people will use is the word rebalancing. And what they'll do is they'll measure how much does a state spend every year on long-term services and supports, and of that spend, how much of it goes towards home and community-based care, so folks coming to an individual's house, attendant cares, and how much of it goes to an institutional setting like a nursing home. And what you'll see is back in the early 1980s, all of the care was really institutional setting. And in part, it's because CMS really hadn't had a lot of programs that would pay for home-based care. But as those what we call waivers continued to spread around the country, more and more states started adopting home care and home community-based programs. And over time, right around 2012, there hit the inflection point where on average around the country, states were spending about half of their LTSS dollars in the home community-based setting and about half on the institutional setting. And so hence the term came out balanced or rebalancing. Indiana, however, we've been fairly flat. We have seen significant increase in home community-based spending, but really we haven't hit that kind of inflection point. And so a lot of what we're looking at also long-term is how do we do that? How do we invest more into the home and community-based side of things? And lastly, we want quality. So when we look at our overall LTSS quality ratings, and this is not just nursing home, but it's home care, it's whether folks have long-term care insurance. It really is the complete continuum of LTSS services. Indiana typically ranks fairly low, about the bottom 10% of states. In fact, 3 years ago in 2017, we were 51st. Now, we have had substantial improvements, some through collaborations with Department of Health and through our Division of Aging, but we're still fairly low in terms of ranking. And you look at the areas that we don't do particularly well in scoring, they are around choice and setting of provider, and we're still last in support of family caregivers. So we have a lot of work, I think, that we can do collectively to improve our ranking. So one of the reasons right now it has been difficult for individuals to age at home is that the system is incredibly complex and incredibly complicated. And it makes it really difficult for somebody who needs care to navigate. So this is sort of right now the way the state is. So hypothetical, grandma, 70-year-old, who's on both Medicare and Medicaid. So she meets Medicare requirements because she's older and Medicaid because of her income and poverty. She falls and hurts her hip. Now, she has a son who typically has been helping her with grocery shopping and comes by every day to check on her. But now she's in the hospital, she's got a broken hip, it gets fixed, and now the family has to make some decisions, right? It's gonna be difficult for her to get back home without help. She doesn't have a ramp, and it's gonna be hard for her to walk. She's not going to be able to drive, and therefore somebody's going to have to provide her food. She's going to have difficulty getting out of bed and getting into the shower and doing all of the stuff that you all do and help with. So the family's going to have to make a decision, how do we help mom or grandma make this choice? Well, right now in our system, which is fairly fragmented, if they want to stay home, first of all, they're going to have to be deemed eligible. And so they're going to have to go through a determination for our A&D or aged and disabled waiver. That determination process can take 6 to 8 weeks. Like, very few individuals are going to have the luxury of waiting that long and providing all of the care for their loved one while they determine whether they're eligible. And then even within there, they're going to have to work often with a AAA or with another agency to try to figure out what do we need. Well, we got to figure out how we get transportation, how do we get food delivery, can we get somebody to build a ramp at our house, somebody that can help get her up in the morning, get her to the shower, somebody that can provide some company and decrease loneliness. All of those things are going to have to be coordinated. And then the family's going to have to figure out who's paying for this. Is this Medicare? Is this Medicaid? If I get on the waiver, how do I navigate that? So it's really complicated. The other choice is, within 48 hours, she would qualify for a nursing home and could go there and get a lot of these same services there. So for many families, there really isn't a lot of choice. The best place is going to be in a nursing home. And for some individuals, that is the best place. Lest anyone think differently, got to have a robust, thriving nursing home industry because they are a critical part of our healthcare system. But for some individuals, they would really like to, and if they had the support, stay home. So how do we create a system that's easier for them to navigate and allows them to do this? Well, we started working on this back in, well, we've been working on this for decades, but we really started to convene stakeholders on this back in 2019. And we got everyone together and we started to say, what are the issues? What are the problems that are existing right now in our LTSS system? And if we're going to reform it, what do we want? What do we not want? And so the big issues came up. I highlighted a little bit. Number one is time to access home community-based services is too long. Right? The system as it continues to grow is not going to be financially viable, and states, which have to balance their budgets, are going to have to make difficult decisions on what and who gets services if we don't start to control costs. We don't have enough home health and community providers. They're going to have to grow to meet the need. And that a lot of individuals and providers don't actually even know all of the options that are available to help somebody stay at home. They don't realize that there's pest control, which I didn't realize, that you can get to your house and you can have a ramp, and there's structured family caregiver. We'll pay for families to care for you at home. And so how do we make sure that we educate folks about what's available? And so we started talking about this and we said, well, what do we want? Well, we want a system where it's easy and fast to get home community-based services, where we're using the best practices and evidence out there, that we're making consumers and providers more knowledgeable about what's available, that we move towards quality by not just paying for services, but paying for better outcomes. So we move to more value or outcome-based services. That we improve the coordination, making it easier for families to coordinate the services that they need and to get them at home, and that we make sure the program's sustainable. And we wanted to avoid unnecessary delays and making it confusing for consumers and not including consumers in how we design or reform a system. And that we don't want consumer demand, like everyone wants to be home, but we just don't have enough providers there. So this is where we were in 2019, and as I don't have to tell you all, COVID hit. And so everything stopped. And I went from being somebody who participated in these meetings to somebody who got the distinct pleasure, and I mean that sincerely, of going to the health department and working with the health department and with the long-term care industry in the state on our COVID-19 response. So we stopped a lot of this work and kind of put it on pause. We did have a little lull in COVID, so during that lull that we had in COVID, there's never a lull, I know, but there was that period, I don't even remember when it was, a year ago when numbers were down, and I went back to FSSA for a bit, and really the goal then was how do we, based on the experience that we've learned so far, how do we reform this system in a way that over time really would push or have more of a shift towards home and community-based services. So I'm going to skip some of this only because it's been covered in earlier talks today. We know about the impact that COVID certainly had in our nursing homes, and I don't need to go over that again. I will say that you can look at this also just at how COVID itself has started to change the landscape of who's getting care where. So folks on our A&D waiver, and our A&D waiver is administered through Division of Aging, and it provides a lot of those home services that we're talking about. That has steadily grown over the last several years. But really, you can look and see that the number of individuals getting LTSS services in a nursing home substantially declined after COVID-19. And I think everyone who works in the nursing home industry is acutely aware of this. Now, how it recovers and when it recovers, we don't really know right now. But it certainly has started to shift the balance more towards home and community-based services. So we ought to be designing a system to really meet what is likely going to be a continued growing demand. So this is what we want to do. And so then the question is how are you going to do it? So what do we really ultimately want to accomplish? And as somebody who is a researcher, you really start off with the outcome that you're interested in. And so when you design a research study, you design what is it you want to kind of look at or what's your hypothesis. And so for us, if we know that 75% or more of individuals, when asked, would like to age at home in a home and community-based system, why don't we make that the objective of our reform? Why don't we start with the outcome that we're interested in, which is getting 75% of new Medicaid members who meet level of care to be able to get that care at home. And so by doing that, by starting off, then we started to work, say, like, if we're going to do that, what are the things that would have to happen for that to be accomplished? And so these are the 5 things that we call our key results. Our objective, more folks getting care at home, and that over time that we kind of shift that cost curve to be more balanced. So number 1, we got to be able to get people services faster. We can't have people have to make a decision on how they're going to care for themselves, their loved one, or their friends for 6 to 8 weeks, we determine whether they're eligible. 2, and we can talk about this a little bit, is that we got to make it easier for people to navigate this system. There's too many players. There's Medicare, Medicaid, Division of Aging, all of those. We've got to make it easier for folks to get care coordination, to have a single number, so to speak, that they can call to. And for us, we're going to build upon the model that we've successfully done in Medicaid already, and that's moving to managed care. So right now in Indiana Medicaid, 85% of folks are in a managed care product. So HIP is probably one of the most publicly recognized managed care programs. So we have, over the last 20, 30 years, developed our ability to and expertise in how do we manage managed care. And so folks that are currently getting long-term service and supports are part of what we call that fee-for-service population. And so moving them to managed care creates some alignment that I'll talk about and the ability to help navigate care coordination better. 3 is how do we move from pay for what you submit or pay for performance to how do we pay for outcomes? And so how do we move from a traditional fee-for-service model to a value-based or outcome-based purchasing model? The 4th is how do we create a data system that allows us to actually have visibility into how people are doing? One that connects individuals across the various data systems they end up with in the LTSS system, that allows us to know what services is an individual getting, what are they not getting, and how do we better link those services to actual outcomes that we care about? So how do we have a robust data system that allows us to understand where people are getting great care and where we need to shift resources? And lastly, and what we're the 5th key result that we started focusing on recently is how do we grow the workforce? How do we grow and sustain the home and community base and really the healthcare workforce in a way that in several years, when we are here, there is going to be a workforce there to provide. And so that is challenging. So that's what we're proposing to do in the work we've started engaging with, again, just a little over a year ago. So part of this, just quickly, is how we're doing this. And this is one of the kind of key pillars that I brought when I came as secretary, is that as we do things, we really want to do them collaboratively. We don't want to make decisions for individuals without their input. And so we have engaged in this process and continue to do so collaboratively. So to date, this slide is a little bit older. To date, we've had over 155 different stakeholder meetings as part of this. And so that is an enormous number of meetings. I know people are probably tired of meetings who've been involved, so thank you. But it involves a large group of individuals. Some of them are in big meetings, some are in smaller focus group meetings. It includes the consumers themselves, so individuals who would potentially move into any new managed care vehicle, or people who are currently receiving services, the providers themselves, the associations that support them, advocacy groups, et cetera. So we're doing lots of meetings with them. I will say Teams and Zoom made those things a lot easier all of a sudden in the pandemic. But we're also reaching out to individuals in the community, so individual providers, individuals who receive services. And we're doing that in partnership with a national organization called Advancing States, who we've had them partner with Indiana Minority Health Coalition. So really going out specifically into communities. And as part of this, they've built a caregiver and consumer focus group, also building a direct service worker focus group. And so they're out gathering information on what people want, how it's going now, and what they would like to see in a new system. And then the last part, if you're talking Medicaid, you're always really ultimately talking about money. And so how do we reform this system financially in a way that incentivizes and really drives towards better outcomes and more home and community-based care? And so as part of that, we've got separate work groups that we're engaged with stakeholders. So that's how we're doing this. So I want to spend a little time on those kind of 5, and with the finance, 6 key areas to give you progress on what we've done to date. So now, as part of this delay that occurs in getting people eligibility, we actually took advantage of flexibilities granted to us through CMS during the pandemic. So when the pandemic happened and we got Appendix K authority, we quickly asked, can we create an expedited eligibility pilot for this? So we do this in Medicaid on the acute care side of things. If you go to the hospital and you don't have insurance, we have a form where somebody can fill out where it says, you know what, you look a lot like somebody who would meet qualifications for Medicaid. So we're gonna say you have Medicaid and you can start getting services. And then they have to finish the application within 90 days. We didn't have a similar process for home and community-based or long-term services and support. So using this authority, we created expedited eligibility, which allowed us in a small number of questions to really say this individual is almost assuredly going to meet full qualifications. Now, full qualifications require paperwork and documentation, all the bureaucracy stuff that always happens. But we decided to do this, and we launched this back in winter of 2020, and we started doing this in several communities around the state. And we decided to also allow the eligibility process to be done by more than just AAA. So right now the AAAs typically do that. And so we allowed adult day cares, we allowed it, an assisted living facility, a hospital, and some other providers, along with our AAAs, to launch this pilot. And as we've done this, we've had 15 providers participating, and we've had about 2,200 applications, and the vast majority of those, almost 2,000, were able to get eligibility immediately. So that's a huge progress for us. Now, the ability to do this, we don't normally have the ability to do this, was really granted through the public health emergency and those flexibilities. And so the work we're doing now is how do we take that and how do we just make that the way we do this moving forward. And so that will require time and working with CMS to create more of an expedited or presumptive type eligibility system for home and community-based services. So we've got a whole group that's working on this now to make this much easier for folks to get services quickly. And part of that process will be defining, is this for everyone? Is there a limited package of services that we provide for a limited period of time? Because we will ultimately still have to do full determination of this. So more to come on this. The nice thing about this is everyone agrees on this key result. Everyone, all the stakeholders, all the group, nobody comes to us and says you shouldn't do this. So this one's good. Probably not the same on this one. This is one that has generated the most interest publicly. And I understand as somebody who is still a provider and the difficulties and challenges of working with insurance companies. But it's really moving towards managed care. And the reason Indiana is moving towards this model is because it really does build upon our existing expertise, existing efficiencies, existing systems that we have already developed, instead of trying to create a new system. And there is a lot of alignment that I'll mention with duals population and a lot of care coordination benefits from this. Now, the other thing about this is we look at other states that move to managed care for the long-term service and support population. We tend to see the same benefits of those 3 drivers that we put in place. So choice, we find that the majority of states that have done this, that more individuals were able to age in home in the community. Quality, more preventative care, less ER visits, more physical health improvement measures, and often more patient experience or member experience benefits. And then cost. Moving to managed care does allow a more predictable cost for the state. And over time, as the system shifts more individuals to care in the home, the overall cost tends to go down because it's about 5 times more expensive to care for somebody per year in an institutional setting than it is in their home setting. And so most states have shown decreased rate of growth, meaning that it's going to continue to grow as the population goes, but how steep the costs continue to grow is really important for us to control. And some states that have caps on their waivers, and again, we have that A&D waiver, we don't have a cap, but a lot of states, by the cost savings, they were able to reinvest and get rid of caps on their waiver services. And so as part of us, the idea that the cost savings along the way can be reinvested into the system is another benefit. And so for us, really the first thing to do is to define who are we talking about. So when we have different managed care models right now in the state. We have got HIP, Hoosier HealthWise, Hoosier Care Connect. All are for different populations. So the population we're talking about here specifically is individuals on Medicaid over the age of 60. And so that's actually important for us. We consciously chose a slightly younger population than the Medicare population because really it gives us an opportunity to do more prevention early on with managed care. So how do we get in? How do we get folks before they have 3ADL needs, before they have needs that are likely going to require them to have a more complex level of care? It will include individuals in nursing facilities, individuals that are currently on our aged and disabled waivers, and it will have all of the state plan services, plus for those that meet criteria, the A&D waiver services and pharmacy and transportation and all that stuff. One of the huge advantages of managed care for us is this, and that's coordination between Medicare and Medicaid. So right now, if you've got individuals who are what we call duals, they have both, right? Medicare, they care about the acute care stuff, doctor's visits, hospital visits. Medicaid pays for the service stuff, attendant care, home meal delivery. But from a financial standpoint, each of those entities doesn't have the same financial interest. So if you end up in a nursing home long-term, Medicare doesn't pay for it. So from their standpoint, it's not really a risk to them. If you end up in the hospital, most part, Medicaid's not paying for it if you're on Medicare, and that's Medicare side. But if it's the same company, the same insurance company, that's managing Medicare and Medicaid, now all of a sudden, the same entity cares about both. And that creates the ability to do better service coordination. So now, when grandma ends up in the hospital with a broken hip, the first phone call that you should be making is to the service side on Medicaid to say, we need that home to be ready so she can come home. We need a ramp, we'll need attendant care, we'll need other folks there. So it suddenly creates alignment. And so when we look at that, right now, like I mentioned, in Medicaid, about 85% of individuals who are on Medicaid are in some sort of managed care product. But Medicare has a managed care product as well. We call that Medicare Advantage, and you are inundated with Medicare Advantage commercials right now because it's now open season for people to make changes. So really that's all it is an insurance company that's administering the Medicare for them. So individuals who are on both this duals population, this is going to be about 90% of the population we're talking about here. So most of them are going to be duals. And they're more complicated, they're sicker, they're more likely to get sick and end up in the hospital with COVID. And our current system really doesn't have a unified care coordination to help them navigate between these two systems. But right now in Indiana, about 45% of folks that are duals have already chosen managed care for the Medicare side, like without advertising, without any incentives. And that has grown rather substantially. And so now if we create a managed care program for the LTSS population, now all of a sudden the same company can be their Medicare and their Medicaid, and really would be incentivized to create better care coordination. And so this is just the growth of what we call DSNPs. That's another way of saying they're on Medicare, they're on Medicaid, and they are on Medicare Advantage. It's substantially increased over the last 5 years. So this is the overall timeline that we've proposed, and so we don't need to go through great details, but we released an RFI, that is, we sent out questions to prospective insurance companies who would bid on this to say, what are the best practices out there? What have you seen to improve care coordination, to improve transfers between hospital and nursing homes and home, and how do you support families? How do you do all the things that we're proposing to do when we build this system? And then we'll use that information along with all of our stakeholder input that we've received to devise what's called a release, a request for proposals, or an RFP. That, if all goes well, will go out in the first quarter of 2022 with an award in late 2022, fourth quarter, and that we would transition really around first quarter of 2024. There's a lot of unknowns between now and then, but if things stay on track, it would be right around that time. So we're looking at this system really starting around 2024. The third key result was quality. How do we move and how do we improve the quality? And so this is really what we call value-based or outcome-based purchasing. And so as part of that, the first thing we really need to do is design a global quality strategy. You don't start with, well, what can we measure, right? Let's go through the list of HEDIS measures and figure out what we can measure. You start with, what are the things that you value in terms of the overall system? And so really for us, that's what we're working on right now. We're working on what is it we value and what is it that we, with our stakeholders, will want to design a system to improve. And so what are the improvable goals that we'll want? And then once we know what we value, then we can go through what are the different measures that we would use down the road to do so. And we'll have that as part of our RFP because that's where we get to tell insurance companies, we value these things and you better help us accomplish them. There are a couple things we know we will value, and so we've already started to measure. One is we value member experience or individual experience. So how do people experience, what do they like and not like about the services they get now through our aged and disabled waiver? And so we launched this summer for the first time the CAP survey. And so that data we're collecting right now, and we'll look at that to see how's it going now and what do they think about it. That way we can measure it yearly as we move towards managed care, and we can find out, is it getting better, is it getting worse? Is the experience improving? And then we can work with managed care to improve member experience so that we find out what individuals are wanting that they're not getting. We also know that we value caregivers. They are the largest unpaid medical workforce in the country, and those are the family and friends who care for individuals. And so how do we provide better supports for them? Because if we want individuals to stay at home and individuals want to stay at home, we're going to also have to consider those that help them. And so how do we better understand their needs and how do we better create training and support and other programs that will help them? And so we launched a caregiver survey this summer as well, and we'll be getting those results back. Well, we have those results back. It closed October 31st, so we'll be getting those results analyzed this month as well. And we'll use those information also as we build this program. Integrated data systems, this is nerdy stuff, I won't get too into it, but the short answer is, how do we do for long-term care and long-term service and supports this whole industry what we did with COVID, right? Very quickly, we went from having no data to having dashboards that you could dial down to your county. You could look at deaths by demographics, you could look at schools. So that was really complicated, and our teams at FSSA were in a partnership with IDOH and MPH to do that because it required connecting lots of different data systems together, testing data systems to hospital data systems to vital records to demographic information. So how do we create that in the long-term service and support industry as well so that we have the visibility for where do people get care, how is their care, how is their quality, how are their outcomes, how does that link or match with services that they're getting? Can we look at programs and say, boy, this is really doing exceptionally well, what's the special sauce they have that we need to spread around? So we're currently creating a cloud environment that gets a little wonky where all of these data systems are coming in, pulling in now some of the Medicare data as well as our Medicaid data plus case manager data, hospital data, nursing home data. That's the goal, is to get it all in one place where we can use it. One of the benefits we've had with this already is we do now ADT, admission, diagnosis, and transfer alerts. So when somebody who's on Medicare and Medicaid is admitted, discharged, or transferred from a hospital, the AAA case managers get a note because they're the service coordinators right now, and they would probably want to know when somebody's going to be potentially coming back home. The last and arguably one of the more difficult, but also one of the more needed, is around workforce. And that we can't grow a system where more people can get care at home unless there are people to care for them, more than just family. And so we have got to think about how do we grow, support, and retain folks in the direct service workforce industry. Now, as part of the recovery, we have a substantial amount of dollars to invest in this as part of our HCBS spend plan. And so we purposely carved this out as the second largest investment after stabilization, meaning that we're going to use these dollars to convene all of the appropriate folks. We're working with other states and working with national organizations to find out what is it that individuals need. How do we support them? How do we create career ladders that make a direct service worker really enter into a work, but if they love it, continue to grow and ultimately end up with a position that is, whether it's an RN or a LPN or a CEO. How do we create supports for them, peer supports and peer groups? How do we, and I don't know what their final product will look like, but things that are discussed, like how do we do loan repayment? How do we do child care support while they're in training? So all of these things that we're working on right now with our stakeholders to figure out how do we invest these dollars in a way that really will substantially grow the workforce. And then lastly really is around the financial reforms here and how do we change the way we pay to really improve what we get. And so there are lots of different work groups here. These ones are sometimes the most animated. So both how do we pay base rates, how do we pay home community-based providers, how do we move Indiana's UPL system or supplemental payment program in a way that moves towards quality and outcomes. And so really for us, I won't spend a lot of time here, we started this the same way we started all of this was by defining what we valued when we did this and what we wanted to do. We want alignment that's across systems, that's simple and uncomplicated. We wanted sustainability. We wanted person-centeredness and value-based purchasing, and we wanted to reduce disparities. And I should mention that from the beginning of this work, we have made sure that as we design this, we're doing so in a way that allows us to better appropriately measure when there are disparities in delivery of care and outcomes, but also design it in a way that hopefully reduces those. So the way we're doing this is we started with a conceptual framework, presented it to the stakeholders, and now we're kind of reforming that a little bit. We have been public about our goal is to, from an aggregate standpoint, really pay the same amount of funding, particularly to the nursing homes, than we do right now as we change the system. So we're not interested in suddenly paying providers less for care that they're providing, and that way we'll offset the cost. But rather, the way to pay for this system is to shift more individuals at home because they have the choice now and the availability to go home. So this was the original thing I showed you. Fall, hospital, complicated system, difficult to navigate, multiple different agencies. This is really what we're striving for. It'd be great if she didn't fall, right? I mean, really, if I was doing this, I'd say we went to the house and we got rid of loose rugs. Although every time I visit my mom, who's 82, she complains about Medicare coming and trying to take her rugs. But that's a separate issue. I keep trying to tell her, because your rugs should be, that's separate. All right, falls will still happen. So now fall, hospital, now as a single plan to call to help for service coordination. And that plan now is incentivized to really understand what she needs and put her in the best location and most cost-effective location. So now she can get rapid eligibility because we have a system that does eligibility quickly. And now they have a choice. They can go home and the managed care company will coordinate all the different services that they would need to stay home. Or for some individuals, they can go to a nursing home, either short-term rehab or long-term, because that may be the best choice for that individual. And so lastly, I'll just kind of end the way I heard lots of folks start by thanking you and thanking all of you, particularly those of you who have been going into and working in nursing homes, those who are attending remotely. I worked also through the pandemic 1 day a week, and I actually did not look up. I don't know what the Webster definition of a hero is. I think my definition of it is somebody who puts other needs ahead of their own. And I think for everyone who worked in long-term care industry and worked in nursing homes and went in nursing homes meets the definition of a hero, truly, and really should be supported as such. I think it is difficult, and I loved that analogy of the 4 phases earlier, because that phase 4 is in many ways the harder one. But I think for all of us who will look back on this, I know, at least I know from my standpoint, 10 years from now, we will be glad we were there in the beginning, we will be glad we were there in the middle, and we'll be glad that we were there in the end. So anyways, I thank you all for the work that you've done and for your attention. It's the end of the day. I'm happy to entertain questions, but I'm also happy to tell people thank you for coming. If you want to.
Have questions from the chat?
Especially to have something wonky and Medicaid-ish at the last. But I didn't show wounds.
I do have questions from the chat.
Sure.
Regarding institutional and HCBS spend, which is from your 7th slide. Does the total spend include IGT dollars?
It includes UPL dollars, yes, which is one of the reasons that probably is so high on Indiana. But it also hasn't changed. It's been fairly flat. But it does include the supplemental payment program.
Okay, and I have other questions here. For example, I recently had a resident who came for rehab and had Medicaid with a Medicare Advantage plan. Following her rehab, she wished to discharge to a licensed residential facility that took Medicaid. We assisted her in starting the process to switch her facility Medicaid to community Medicaid waiver on March 30th, and she got approval, and it was complete on June 23rd. Rather than 72 hours, she waited 84 days.
That's right. That's the current system.
By her remaining at our facility until she was approved, this cost the state a minimum of $12,509 additional. Seems like quickening that process could allow people to choose where to live quicker and save tons of money. I'm wondering why the focus on improvement cannot start within FSSA. If I have issues with my dietary department, I focus on quality improvement rather than outsourcing to a private company. So just accompanying with that are the questions about why can't there be an increase in the speed for approval for other services offered, and why is managed care the only solution to the problems shared?
Yeah, for the first one, that is the system today. That is exactly why we want to reform it. That is the whole goal of Key Result 1, is how do we make that service faster? In the sense of why can't we turn it on right now? As with everything in Medicare and Medicaid and CMS, is it requires authorities, approvals, payment mechanisms, and systems of accountability. And so those take time to build. And so, by having the ability to do this during the pandemic, by the ability to do a pilot study, that really has given us a lot of information about what has worked with this process. And so we'll use that and work with CMS. But it is our goal in the next couple of years that is just the way we do it. So couldn't agree more. That's a great example of the current system. In the sense of why is it the only model? It's not the only model. I mean, just to be fair and transparent, there are other models. We have a current model. We have a current fee-for-service model that we're doing and that other states do. It's just that our current model has not been very successful. Are there models within fee-for-service? Sure, there are other models within fee-for-service. The reason Indiana really is moving towards managed care is because that is the system in terms of Medicaid that Indiana has really built and grown with. And so we have developed efficiencies by having knowledge over time with the managed care and the way we oversee them. It also allows us to create efficiencies between managed care programs. So all of a sudden, like, we can create over time things like more uniform PA process for individuals who are in HIP with one insurance company, and then end up in, say, Hoosier Care Connect with different insurance companies, so that it's easier for them over time and providers. We can create better alignment between programs, like if we have Hoosier Care Connect, they have D-SNPs, which is the Medicare Advantage programs. As we develop managed care here, we can also assure that we have the same companies providing those D-SNPs, so that you don't have an individual who might go from Hoosier Care Connect to this new product and suddenly has to have a different Medicare program as well. So we can create alignment between the programs, so as individuals transition across them, that they're easier. And, for better or for worse, the insurance companies are big. They have lots of resources and lots of abilities to do things that we can't by law with Medicare and Medicaid do. So, for instance, we can't pay for housing. That's just the rules. But they could. They could if they decided, boy, if I could create a program to help these individuals stay in their home because they're not affordable, they would have the ability to do so if in the end that resulted in them paying less because they were at home versus in a nursing home. And they've done that, for instance, in the Medicaid HIP population, where they created a housing first model called the Blue Triangle, where folks with substance use disorder could actually get a free place to stay and then while they're there, they give them the services and the care that they need and ultimately move them out into their own housing. So they also will have some flexibility and some competition that they can create between themselves to create innovations in the way that we can't right now as the state. So it's a great question. It's one that we're going to get asked, and we continue to get asked, and we'll get asked again this session. But really for us, it allows us to build upon the model that we have the most experience and most success with already.
When does Indiana expect to do away with the UPL funds?
I don't think we expect to or hope to or plan to do away with UPL. So the UPL system, as folks may or may not know, is a really complicated system, but it's a system with CMS that allows nursing homes that are owned by non-governmental state organizations to really bridge the gap between what Medicaid pays and what Medicare pays. It is not our intent or our plan with this program to do away with it. What we'd really will have to transition it from a fee-for-service system into a managed care system. Other states have done that as well. Indiana is not the only state with a UPL program. But really, it's long-term, once we make this transition, how do we better link those UPL payments to quality outcomes? And how do we create a more value or outcome-based system? And so that is really, I think, first step is how do you move it? Second step is how do we better link it to quality and outcomes? It's a substantial amount of money, and it's important for providers, particularly for providers of complex patients. So really what we'd like to do with it is to keep it and just to better link it to quality and outcomes.
Okay, and has there been any thought about how the state of Indiana is going to improve the workforce that serves A&D waiver clients? That seems like a barrier that would sabotage the plan to move towards more in-service on the waiver.
Yeah, it's a great question. There are a couple things right now in our favor as we do that. Number one is this is not quite, but almost 3 years away, so we have time as we start to build and grow that workforce. Two is we have a substantial amount of investment coming from the Recovery Act that will allow us to invest in this. So step one is to talk to them, and we're doing that now with our key result group 5, is how do we talk to the direct service workforce, hear from them directly, talk to the industry and talk to experts around the country about what would be needed to grow and sustain this workforce. Then how do we invest those dollars in a way that will do so? It is an important point. I don't have what we're going to be doing yet. We're currently in the kind of stakeholder discussion phase and talking to everyone from the Ivy Techs to individual providers to say, what would this look like in Indiana? How do we create a system unique for us that would help recruit, retain, and grow the workforce? But that is paramount to every state's system moving forward. And so we're not unique. It is everywhere around the country. One of the advantages right now is the attention this has brought with COVID on the pay and the benefits in the direct service workforce. So I do think even with the proposed bill that's currently right now in the federal government that there is a likelihood of increasing some of those over the next several years. So hopefully timing, it works out really well for us that over the next 3 years as we invest in this that we'll be able to grow the workforce to meet the demand. It's a good question.
Okay, I do have a couple more from the chat.
It's the end of the day.
Another brick wall for those transitioning from nursing home to A&D setting is transitioning their Social Security income back to individual from the nursing home due to lack of response from the Social Security offices. Do you plan to work with Social Security offices on this?
I've not heard that. That's a great question. I bet our team knows about that. I don't know. That's a great question. I will look into it. I mean, we have one of the advantages of our agency is we do have the DDB, which is the Disability Determination Bureau, which is a Social Security agency. But on transferring Social Security benefits from the nursing home back to the individual, that has not come up, but I will look into it. It's a great question.
Okay, and you mentioned transportation for those on Medicaid. The current system through Southeast Trans is not working. No available transportation when needed for our residents.
Somebody to mention Southeast
to
Trans.
go to dialysis or needed appointment. Returns to hospital, decline in health equals F-tags. Are you planning to fix this system?
Yeah, I mean, every system that we oversee in Medicaid is a system that we want to improve. And so Our transportation system, our non-emergency medicine transportation system is one of those. And certainly we have seen improvements in that system over time in terms of less missed rides, but it's not perfect. And there are people who still have challenges getting rides. COVID, as with everything else, made those challenges even greater. So of course, we want to improve that service. I will say, that is an example of how difficult and complicated it can be in the fee-for-service population when you try to provide a new program and a new service. Medicaid and the managed care entities do transportation as well. It's hard. It's hard across the board. So, but yes, absolutely, it's something that we're continue to improve. Boy, I got the hard questions, but thank you all.